So thank you, Rajesh, for those kind words, and thank you all the other panelists. Thank you for joining. And yeah, my job is to talk about CPAP and HFNC. So the objectives of my presentation are to talk more on bubble CPAP, because somehow I like bubble CPAP more than other CPAPs. How do we use? How do we start? How do we monitor? How do we wean? And when do we say baby has failed from bubble CPAP? And what all we can do to improve the efficacy of bubble CPAP. And also we'll turn some, what are the other methods we can learn on this online sources, and what are the other methods by which you can learn this bubble CPAP and other CPAP. I'll also touch upon on HFNC while I'm dealing with this case. I'm going through a case-based scenario, easy to understand, and for all of you to see what you can do when you get a case like this. So here we have a 30 weeks baby S, 1.35 kg, girl child. The baby was born by preterm labor, received 1 dose of steroid 6 hours prior to delivery. So incomplete steroid covered. The baby was born by C-section, no asphyxia. Baby started having respiratory distress at birth, and so he was shifted to the NICU, which is almost 4 hours from the birthplace, and he was shifted on nasal oxygen. At admission to the tertiary care NICU, the temperature was 36 degrees Celsius. He had severe respiratory distress. SA score was 7/10. And on nasal oxygen, he was maintaining 93% nasal oxygen. So I want you to be a little more interactive now on this. Now tell me what you would do if you see a baby on having moderate to severe distress and requiring oxygen. Maybe you can put in chat box what you would do. He's already maintaining good saturations, and he has moderate distress, but he has good saturations. So what will you do for a baby like this coming at 4 hours of birth? So what type of respiratory support you want to give for this baby? So what type of support you want to give? So to say respiratory failure is okay, mechanical ventilation. So we didn't say the baby was late rescue surfactant with invasive ventilation. So if that was the answer, I would not have taken this class. So very good. So obviously, whatever be the respiratory distress for a preterm baby, the choice is non-invasive respiratory support. And among the non-invasive respiratory support, the choice most of the time, first choice is CPAP. So if you have this is called primary respiratory support. The respiratory support for a baby with respiratory distress is primary respiratory support. So CPAP is the choice for these babies. And some people also agree that you can use other modes of non-invasive ventilation apart from CPAP. So I said the Silverman score was 7/10. So how do we do the Silverman score? The photograph here shows the components. You have upper chest, lower chest, xiphoid, and nasal flaring, and also expiratory grunt. So maybe you can let me know, how do you define upper chest and lower chest? So what parameter helps you to differentiate upper chest from lower chest? Just one word. Can I know the differentiation from upper chest to lower chest? So each of these 5 parameters, maybe you can write in the chat box. Each one of these parameter you can see. Upper chest you have 0, 1, 2. Lower chest you have same. So good. So it is a mid-axillary line. You have to see from the baby's side. You have to come down to the baby's bedside and see the mid-axillary line. Above the mid-axillary line is upper chest. Below the mid-axillary line is lower chest. So how the chest and abdomen are moving, whether they're moving together or abdomen is moving and after that chest is coming up. So depending on that, you score 0, 1, 2. Lower chest is this chest below the mid-axillary line. I can see here. And xiphoid sternal is very simple. Nasal flaring is simple and grunting is simple. So maybe you can do the scoring for this baby and put it in the chat box. What is the score for this baby? I'm sure all of you can see the video. Look at the nasal flaring here from the grunt. Look at the upper chest. Look at the lower chest and sternal retraction. So grunt, nasal flaring, upper chest, lower chest, and xiphoid. So what is the SA score for this baby? What is the SA score for this baby? You add all the 5 parameters, you'll get the SS score. I need people to interact. So please let me know what is the SS score for this. So upper chest was how much? Upper chest was how much? The abdomen is going up, the chest is not coming up. So this is 1. How much is the lower chest? Again 1. Sternal 1. And flaring is there. So you keeps able to see from a distance 2. And you are able to hear the grunt. So score is 2. So total score is 7. Very good. Wonderful. So this baby has a total score of 7/10. And we said this baby has moderate respiratory distress. He's 30 weaker, 1.3, moderate distress. So we will start CPAP for that baby. Babies who have good respiratory efforts, not distress, good respiratory efforts, you start them on CPAP. If the efforts are not good, or if the baby is not breathing, then you think of ventilation. But all babies with respiratory distress, irrespective of the upper point, any preterm baby less than 35 weeks with a Silverman-Anderson score 3 or more, that baby is a candidate for CPAP. So this baby, so what respiratory support? We already discussed that we'll give either CPAP or other nasal mode, nasal IMV. And how do we give the support? So if you're thinking of giving CPAP, how do we give and what to monitor? So this is what we'll learn subsequently. Okay. So we will give CPAP for this baby, but other choices are what? What are the other choices apart from ventilation? Obviously, ventilation is not a choice because the baby has good efforts, although he has respiratory distress. Other choice is nasal IMB. So, but I said we prefer bubble CPAP. Why do we prefer bubble CPAP over nasal IMB? Maybe 1 or 2 answers I can get. Why do we prefer bubble CPAP over nasal IMB? So in bubble CPAP, we call it as CPAP only because you're giving pressure both during inspiration and expiration. In ventilation, we call PEEP because it is gives only during expiration. So, but why we prefer bubble CPAP over nasal IMB? Because nasal IMV is given through ventilator. Bubble CPAP doesn't require a ventilator. It's a different machine. With one ventilator, you can buy 6 to 7 bubble CPAP machines. So it's more cost effective. It's easy to do, better to monitor, easy to monitor. So all your nurses can easily adopt to giving bubble CPAP. So that's why we prefer bubble CPAP over nasal. And the flows are unregulated in bubbles in ventilator CPAP, but the flows are well regulated in bubble CPAP. So since this baby was less than 35 weeks, had a Silverman score more than 3. So this means the baby, although this baby had 8/7 or 8/10, but Silverman score more than 3, this baby is ideal candidate for starting on CPAP. So CPAP can be given either through bubble or ventilator. We prefer bubble for cost-effective reasons. So all babies less than 35, less than 2 kg, if SA score is more than 3, we prefer to give bubble CPAP. So now what do you require to give bubble CPAP? These are the minimum components which you require for giving any bubble CPAP or for that reason any CPAP. You need compressed air oxygen sources. You need a good blender. You need a flow meter and you need a servo humidifier and you need a pressure generator. So the bubble chamber here is a pressure generator. This one delivers the gases, the warms and humidified the gases which are coming from the compressed air sources. And the blender is used to titrate the FiO2 and flow meter will titrate the flows which are coming into the circuit. Definitely, these are the 4 minimum components you need for giving any bubble CPAP. Now you can give bubble CPAP with you can give CPAP either with a bubble CPAP machine like what is seen in the left, or you can give it with a ventilator. But we prefer bubble CPAP because it's cost effective, flows are well regulated and easier to do. And when you want to give CPAP, you can do it with any one of the 3 interfaces which are shown here. You can use Hudson prongs, you can use mask, or you can use Ram's cannula. So the choice is yours, but continue to use the same prongs for improving experience. And the more experience you have in any nasal interface, the lesser are going to be the side effects of nasal interface. But whatever interface you are using, it should be binasal prongs or it should be a mask. So this is the interface and this is the machine, bubble CPAP machine interface. Now, how to give bubble CPAP? So I'll show you how to set the bubble CPAP machine so all of you can see this.
So what is ClickUp? ClickUp is an all-in-one productivity software where you can manage everything and anything related to your work.
Here, can you see this? Can you see the video? Just say yes if you can.
It's not running.
Preparation includes
No?
assembling the machine,
No,
bubble
now-
CPAP, a cloth and a disinfectant for
Yeah,
cleaning
yeah. Now it's
machine,
running.
gloves,
No?
and distill.
Rajesh?
Yeah. Again, restart.
Okay.
Clean the machine with
Now it is running.
IDEX or any other approved disinfectant. Clean the heater wire and temperature probe with a clean and soft cloth and sterilium. Connect the machine to compressed source of air and oxygen. After washing hands and wearing clean gloves, open the disposable CPAP circuit. Fix the water chamber onto the servo humidifier and fill it with distilled water. Use the autofill option of fixing the distilled water bottle to a stand for filling the water chamber. Fill the bubble chamber with clean or distilled water and fix it to a slot available on the CPAP machine stand. Now fit the safety device between the flow meter and the water chamber of humidifier using the green gas tubing. Now connect the blue inspiratory limb to the other port of the water chamber. To the other end of the blue inspirator limb, lock the white expirator limb of the bubble CPAP circuit. The second end of the expirator limb is connected to the bubble chamber. Fix the heater wire and the temperature probe to the appropriate slots available in the humidifier and the inspirator limb of the bubble CPAP circuit. Switch on the humidifier and set in invasive mode as shown here. Watch for bubbling in the bubble chamber. Set the FiO2 flow and pressure to appropriate level. Wait for the humidifier to display a temperature of 37 before connecting the circuit to the patient.
So the salient points which I want you to remember are as shown in the figure there. One, you need to connect to center line. You need to use a good servo humidifier which delivers the gas to the nose at 37 with 100% relative humidity. The water level in the bubble chamber and the water level in the humidifier should be appropriate. You should put the humidifier in invasive mode, not in non-invasive mode. And then you need to develop a good technique of interface. Once the temperature on the humidifier becomes 37, then you connect the machine to the baby. Now, once you connect the machine to the baby, you need to know what knobs you have to set and how to adjust the parameters. Basically, in CPAP, whatever be the mode of CPAP, there are only three knobs. The one is the flow knob, which is the flow meter. The second is the FiO2 and third is the pressure knob. So the flow, when we are starting bubble CPAP for any baby, we keep the flow at 5 liters per minute. This flow is sufficient to deliver pressures of 4 to 8 centimeters, which is mostly required for patients on bubble CPAP. And the pressure we start mostly with 5 centimeters of water. And the FiO2 we set at 30%. So this is the starting flow, pressure, and FiO2. So a rule of 5 for flow and pressure, and 30% FiO2 we start the baby on CPAP. Now, after you start the baby on CPAP, you need to adjust the settings. So how do you know your flow of 5 liters is adequate or not? You look at the bubbles in the bubble chamber. If these bubbles are continuous, you know your flow is adequate. That is 5 liters is adequate. If there are no bubbles, there could be some leaks in the circuit. Your prongs are not fitting well, or the baby is crying. So you soothe the baby, you nest and cocoon the baby and ensure that the bubbles are sealed, or look for circuit leaks. Now, how do you know your pressure of 5 centimeters is adequate or not? By looking at the retractions in the baby. If there are recessions or retractions which are subcostal, intercostal retractions, then you need to increase the pressure. If there are no retractions, if the chest looks normal inflated, that means your pressure is adequate. You can also auscultate the chest and you'll be able to hear the bubble sounds. If you are able to hear the bubble sounds and if the retractions are minimal, that means your pressure is adequate. How do you know your pressure is high? The chest looks hyperinflated and there are no retractions. You know that whatever pressure you are giving is high for the baby. You come down on the pressure. Now, the third point is how do you know that flow FiO2 of 30% is adequate for this baby or not? So when you set 30%, you should be able to see a saturation of 91 to 95%. So flow is for bubbling, pressure is for recessions, and FiO2 is for saturations of 91 to 95%. Now, how do we adjust further? So these are the three knobs which we have, and that is how you will adjust the flow, CPAP, and FiO2. Now, if the baby's saturation are less than 90% and if there are retractions, you need to open the lung. So to open the lung, what can you do? You keep increasing the pressure from 5 to 6, 6 to 7. So if there is hypoxia with retractions, you keep increasing the pressure from 5 to 6, 6 to 7 to a maximum of 7 or 8 centimeters. But if there are hypoxia, that is saturation is less than 90%, but there are no retractions or minimal retractions, instead of increasing the pressure, then you increase the FiO2 to get saturation between 91 to 95%. If there are no retractions means your lungs are well inflated. The lungs are inflated, hypoxia is because of low oxygen. So you increase oxygen. If there are retractions means there are still, your lungs are atelectated. So you open up the lungs by giving FRC, by giving pressure, by giving increasing pressure. So hypoxia with retractions increase the pressure. Hypoxia without retractions increase the FiO2. So you can go in that order. First, think of increasing pressure and then increase the FiO2. So then how do we decrease? If there is hyperoxia, that is your saturations are more than 94, 95%. And if there are no retractions or many mild retractions, then what should you do? You come down on the FiO2. While you are increasing, you kept on increasing the pressure first and then the FiO2. While you are coming down, so since there are no retractions, hyperoxia is there, you come down on the FiO2 to as low as 30%. Suppose the pressure of baby is on a pressure of 7, FiO2 50%. So what you should do is you keep coming down the FiO2 to 30% and come down on the pressure from 7 to 6, 6 to 5. Once you are in a pressure of 5, FiO2 30%, and subsequently you come down on the FiO2 from 30 to 25% and 25 to gradually to 21%. Once you are on 21%, decrease the pressure from 5 to 4. Once you are on 4 and 25%, the baby no more requires CPAP. So you can change from CPAP to HFNC or to room air. So going up, increase the pressure, then FiO2. Coming down, first come down on the FiO2 to 30%, pressure to 5, 21%, and pressure to 4. So this is how you go up and go down based on the baby's condition. So this baby was started on a bubble CPAP with binasal Hudson prongs with a pressure of 5, FiO2 30%, and flow of 5 liters per minute. Over the next 24 hours, the baby's SA score decreased from 7 or 8 to 3 by 10. FiO2 was still 30%, flow was 5 liters per minute. Over the next 12 hours, that is next 36 hours after starting CPAP, the score has almost become nil or 1 of 2 by 10. CPAP was then decreased from 5 to 4 and FiO2 to 25%, and flow was kept as 5 liters. Now, what is the plan now? Either put him on oxygen or room air. This baby, while CPAP was started, orogastric tube also was placed in and a caffeine loading dose was also given. And this baby was also started in minimal enteral nutrition of 2 ml too early, only mother's milk. So this is how you manage a baby on bubble CPAP. Now, we have decided that the baby is already on minimal settings, FiO2 25%. So we want to shift into either room air or HFNC. If the baby is more than 1 kg, you can start the baby on HFNC. The baby is less than 1 kg, you continue the baby on CPAP of 4, FiO2 21%, or remove and see if the baby has apneas, then you can continue. If the remove and see if the baby has apnea, you restart CPAP till the apnea resolves or for 24 to 48 hours after CPAP. Now, if you're starting the baby on HFNC, that is a baby is more than 1 kg, when you're switching from CPAP to HFNC, keep the flow 5 liters. Whatever FiO2 you remove from CPAP, you continue the same FiO2. And subsequently, if there are no retractions, keep increasing the flow. Sorry, if there are retractions, keep increasing the flow. If retractions are not there, saturations are low, keep increasing FiO2. So you can use a maximum of 30-40% FiO2 and a flow of 7 or 8 liter on the HFNC. But when you're coming down, come down on the FiO2 to as low as 21% and flows to 2, 5, 4, 3, 2. Once you're in 2 liters and FiO2 is 21%, you can bring the baby back to room air. So this is one scenario where baby was started in bubble CPAP, improved, caffeine was given, enteral nutrition was started, and baby is switched over to HFNC. Now let us look at the second scenario. Same baby, we started on bubble CPAP, but the infant was started on bubble CPAP with a pressure of 5, FiO2 30%, and flow of 5 liters. What happened over the next 4 hours? The baby's retractions remained. SA score from 8 or 7 came to 6, but still retractions were significant. Baby was hypoxic. So what do you do now? Since the baby has hypoxia and retractions, we keep increasing the pressure from 5 to 6, 6 to 7. So the pressure was increased to a maximum of 7 centimeters, but if saturation was still low, so the FiO2 was increased gradually from 30 to 35, 35 to 40, 40 to 45, and then to 60%. But flow was kept at 5 liters because the flow bubbles were always seen and bubbles were heard in the chest. So while you are on this pressure of 7, FiO2 60%, baby continues to have retractions and hypoxia. What do you do now? Maybe you can write in the chat box, what do you do now? Because your CPAP still not able to open the lung, not able to give normoxia for the baby. So what do you do now? Okay, so CPAP fail is very good. Mechanical ventilation, okay. Okay, nasal IMV is another option, very good. Intubate and mechanical ventilation. Okay, so these are the options. Yes, we can either continue the baby on CPAP. So we need to see how do we continue, or we can switch over to nasal IMV, or we can go to ventilation. But before you go to nasal IMV or ventilation, first you have to see whether your CPAP is adequate or not. That means you are able to deliver the pressures to the lung. Bubbles are heard, bubbles are seen, whether humidification is all right or not. Temperature is 37, there is no condensation in the inspirator limb, and FiO2 30% you are setting, whether actually delivered is 30% or not. So you need to cross check the blender using a FiO2 monitor. So if you have done all this, then get to an X-ray and see whether you are dealing with RDS or some other disease. So the X-ray was done. So what happened is, so before we do the X-ray, so look for pressures. So bubbles were seen in the bubble chamber. That means no leaks in the circuit. Bubbles were heard in the chest. That means air is reaching the lung. There was no condensation in inspirator limb. So, and temperature was 37. So humidification is appropriate. Seal was appropriate and fixation was good. Nasal interference is good. So day after checking for adequacy of CPAP, X-ray was done. And this is the X-ray. So what is the X-ray showing? X-ray showing classical reticulogranularity, air bronchogram, and probably low volume lungs. So 6 spaces, and so ground glass or reticulogranularity and air bronchograms are seen here. So you have a baby on CPAP who requires a pressure of 7, FiO2 60%, and you have an X-ray like this. What do you want to do now? Would you want to go for NIV? You want to go for ventilation, or you want to do something else? Very good. So obviously our choice would be to give surfactant for this baby. So maybe even before increasing the pressure, I would have got an X-ray. And if X-ray was showing this, while continuing on CPAP, I would have intubated, given surfactant and extubated back to CPAP in this baby. So this baby was intubated, surfactant was given and extubated back to CPAP, and other supportive care was continued, like correcting hypoglycemia, hypocalcemia, anemia, polycythemia, fluid management, inotropes if the baby has shock. Then more important is to give relieve pain, nesting, cocooning, oral coating of the mouth with colostrum, and gavage feeding. The tip of the feeding tube should be above the level of the tummy. So over the next 12 hours, this baby was started insured, CPAP was continued, and for the next 12 hours, you can see the retractions has come down, saturations are well maintained. So gradually FiO2 was decreased from 60% to 30% in steps of 5%, and the pressure was reduced from 7 to 6, 6 to 5. So came down on FiO2 first, and then the pressures. So on these pressures of 5 and FiO2, subsequently, If there are no retractions, if saturations are normal, we can come down on the FiO2 to 25 to 21%, and then pressure from 5 to 4. So subsequently, again, 4 and 21%, we can switch over to HFNC. The baby is more than 1 kg, less than 1 kg, we can either continue CPAP for some more time till baby is apnea free, or we can give a trial of CPAP, room air, and if the baby is not tolerating room air, we can switch back to CPAP. So when do you say failure of CPAP? If a baby on a CPAP pressure of 7 or 8 centimeters and FiO2 requirement of more than 60%, and baby continues to have retractions, continues to remain saturation less than 90%, you consider that baby as CPAP failure. But before you declare baby as CPAP failure, you have to ensure that adequacy of CPAP is there, and also ensure that you have taken care of other things like caffeine, supportive care, feeding, and also ensure that you're given surfactant if there was RDS on the X-ray. So if baby fails CPAP, you have two choices, either nasal IMV or mechanical ventilation. So what all things we can do to improve the efficacy of CPAP? Most important is interface. The interface can be any one of them, but continue to learn the art of interface fixation so that the injuries can be prevented, leaks can be avoided, and baby is comfortable. So I would prefer bubble CPAP. For bubble CPAP, you need to ensure blended air and oxygen, and servo humidifier, and a good pressure generator, and water column in the pressure chamber should be well maintained. So, and ensure correct humidification of 37 on the humidifier and no condensation in the inspirator limb. The inspirator limb should be warm to touch. Always monitor the baby, the interface, and the machine. I'll show you what all to monitor in each one of these components. Simplify the baby settings, mainly the pressure of 5, flow of 5, FiO2 to suit the saturations. And always note the troubleshoot on a bubble CPAP so that you can make changes immediately, and use of adjuvants like caffeine, surfactant, feeding will improve the efficacy of CPAP. And always have a backup for referral or ventilation, because 15 to 20% of babies can fail CPAP. Then you should be able to refer these babies on CPAP or on TPs and then start them on ventilation. So as I said, any one of the three interfaces are good, but whenever you're using Ram's cannula, please do not use cannulate. There should be some gap at the interface in the Ram's cannula. You can fit about 80% of the nasal interface, nasal cavity with Ram's cannula. Hudson prong should be snugly fit, and the mask should be fitting well. So if you continue to use the same technique, you will decrease the injuries. So regarding the CPAP machine, you need a compressed air and oxygen, you need blender, correct blender, and a flow meter. You need a servo humidifier, and you need a pressure generator. So suppose your compressor is not working, or your air compressor is not available, and you don't have a good blender, what can you do? So you can, nowadays you have machines which run on cylinder oxygen, and you have machines like these which have inbuilt compressor, inbuilt flow meter, and you can measure the FiO2, and you can increase this FiO2 by increasing the inlet oxygen connected to this machine. So this has an inbuilt FiO2. It can measure the pressures, it can measure the flow, it can measure the flows, and you can increase FiO2 by increasing the oxygen inlet to the machine. So, but you need to have a servo humidifier and a pressure generator appropriately fitted to a CPAP machine. Always you can use kangaroo mother care while doing CPAP, and ensure that the mother is comfortable, the baby is comfortable. For long CPAP, more than 1 day or more than 2 days, combine CPAP with kangaroo mother care, you will get the best benefits. So this is a monitoring chart which has baby monitoring like heart rate, respiratory rate, Silverman score, breath sound, urine output, CPAP pressure, and FiO2. You have the patient interface monitoring, where you look at the distance between the columella and the interface. You look at the nasal skin is blanched or not. The columella septal aspiration, constantly look for that. Do a oral nasal suction, ensure that the OG tube is in place and the end is the tube is open. And the machine always looks for bubbles in the bubble chamber. Temperature displayed should be 37. The tubings, the circuit should be below the level of the babies, and the flow rate should be 5 liters, maximum of 8 liters, because you don't require flow more than 5 liters most of the time. Only when there are leaks, your flow requirement will be higher in bubble CPAP. And you can have a small chart like this, which can be fixed in any NICU, where it tells you what babies you give CPAP, how do we give CPAP, and what pressures you start if you're starting for a primary RD like this. Suppose you're starting CPAP for post-extubation. So what are your starting pressures? Pressure of 5, FiO2 is same that as in ventilation, and flow of 5 liters per minute. Suppose you're giving CPAP for apneas, FiO2 to 21%, pressure of 5 and flow of 5 liters. So for extubation, post-extubation FiO2 is same that of ventilator. For CPAP apnea 4 or 5 pressure, FiO2 21 or 25% based on the needs of the baby. And you should know what to monitor for, how to adjust the pressure, flow and FiO2, how do we increase and how do we decrease, and what troubleshoot we need to know. What are the other things you should know as far as CPAP like Silverman score. So this is just a chart which is highlighted what all components, initial settings, adjustments, nursing care, weaning and failures. So this troubleshoot is very important. Suppose you have a baby with hypoxia and retractions. Air entry is not there. So bubbles are there. So what is the reason? So that means bubbles means the pressure is there in the circuit. Bubbles not heard means the bubbles are not reaching the lungs. So which means lungs are still attracted. So what is the reason? That means there is a block in the nose. You open the nostrils and clean the nostrils. So then you see the prongs are well fitted. If the bubbles are heard, the pressure is reaching the lung. Still retractions are there, increase the pressure. So second scenario, hypoxia, no retractions. Good air entry. Bubbles are seen. Pressure is there in the circuit. Bubbles heard, pressure is reaching the lung, but baby is hypoxic. What could be the reason? Lungs are open. Maybe baby requires little more oxygen, so increase FiO2, or your blender is not working. You said 30%, but the blender is giving only 21%. So cross-check the blender malfunction, or there is no lung disease, so lungs are open, but baby is hypoxic because of heart disease or PPHN. So keep increasing the FiO2. Third scenario, saturations are low, retractions are there, breath sounds or bubbles are not heard, bubbles are not seen. If bubbles are not seen means the circuit pressures are not adequate. So that means there is leak somewhere in the circuit, leaks in the mouth of the baby or leaks are there at interface. So you comfort the baby, calm the baby, ensure that there are no leaks so that bubbles are seen and bubbles are heard. Now, if there is condensation in the inspiratory limb, what does it mean? The heating in the inspiratory limb is not happening. Either heater wire is not working, or a temperature probe is not working, or your room temperature is so low. But you should be able to see some condensate in the expiratory limb. There is no condensate in the expiratory limb, that means your room temperature are very high, or your humidifier chamber is not working. So these are some simple troubleshoots you can look at based on the condition of the baby. So some more tips. So you can do CPAP for even for a cleft lip, cleft palate baby. This used to be a contraindication, but no more, because you can cover the nose and mouth with a mask. The resuscitation mask you can use, and you can tie the resuscitation mask to the neck of the baby or to the head of the baby and connect it to a T-piece, inspiratory limb, expiratory limb, and you can give CPAP for this baby. I have a orogastric tube in place so that this is coming underneath, and this mask can also be used to deliver CPAP for babies. CPAP can also be used for meconium aspiration syndrome babies. If you have a term baby, if the Silverman score is more than 5, then that term baby is a need for CPAP, irrespective of the etiology, whether it is pneumonia, RDS, TTN or MAS. CPAP is the choice for even term babies with respiratory distress. And there again, you start with a pressure of 5, FiO2 30%, flow of 5 liters. Depending on the retractions, you keep increasing the pressure. Depending on the saturation, you keep increasing the FiO2. But in MAS, we try to avoid pressures more than 7 or more than 6. So when we have studied the need for CPAP in MAS, we have realized that if you start early CPAP compared to oxygen, you can decrease the need for surfactant, you will decrease PPHN, you will decrease the need for ventilation. In many of this, you can see they here that 3% versus 25% is a huge difference when you start early CPAP for MAS babies. So high flow nasal cannula, we have once seen the high flow nasal cannula can be given post removal from CPAP. It is also can be given when you extubate the baby from mechanical ventilation. You have two choices. One is 3 choices, either CPAP, nasal IMV or HFNC. HFNC post extubation is as good as CPAP. But when you're giving post extubation, you have to give a flow of 5 liters, FiO2 same as that on mechanical ventilation. And there is no pressure here. So only flow and FiO2 you set on HFNC. But very important is for the prongs. The prongs of HFNC are very different that of the prongs of CPAP. CPAP prongs are wide, they snugly fit. HFNC prongs are small, very narrow. They should not occupy they should occupy less than 50% of the nostrils, and the prongs are tapered at the end. When they go inside, they're tapered. They're giving a whiff of air, no pressure. Whatever extra flow is there, it is coming out through the nostrils. So do not use CPAP HFNC for primary respiratory distress. We prefer CPAP or nasal INV for that condition. But you can use the same circuit like OptiFlow. The same circuit you can use for giving CPAP or HFNC. No expiratory limb and no bubble chamber is needed in HFNC. Only the inspiratory circuit and HFNC prongs are sufficient to deliver, convert CPAP to HFNC. So monitoring for babies on HFNC, you need to monitor only the flow. Sorry, for a baby monitoring and bubble CPAP, you need to monitor for the water levels in the humidifier chambers and the bubble chamber. The humidifier chamber should be autofill. So use distilled water, and your bubble chamber preferable is to use drinking water or potable water, or clean water. Because this water is not going to the baby, you can use drinking or potable water. Always cross-check the blender with a FiO2 monitor and ensure that the flow meter is set at 5 liters per minute. And the pressure, if you're setting at 5 and 6 is visible here, from the water level, the tube is immersed 6 centimeter inside water. So if it is 7 here, from the water level, it is 7 centimeters inside water. So that means the water level should be constant, and then only the whatever is seeing on the pressure chamber is actual pressure delivered to the patient. So we have already discussed what monitoring chart we need, and you want to learn more on CPAP or nasal IMV, look at this site, preterm care eliminatingrop.com. This is entire module on CPAP. Everything which we have discussed now are going to be there, and you can subscribe or go to my YouTube channel, and you will see everything related to CPAP. Most of these talks are already available. Most of the videos are available, or you can buy a CPAP module book, or you can attend a CPAP workshop like what you're doing now, IAPNEOCON or IAPNEOCHAP, or any of the workshops you can attend for a single day. You can learn a lot of CPAP and nasal IMV. The best way would be to observe for 15 days in a unit so that you learn a lot of art and science of CPAP when you work in depth in the unit. So these are some of the options for all of you to learn how to learn and how to do CPAP. Some more tips. So maybe you can tell me what is the problem here. There are two photographs shown here. So the one on the left and one on the right. So which is correct and which is wrong, and why the left or the right is correct? So first tell me which is correct. The left or the right? So mouth can be open in babies on CPAP. Please do not occlude the mouth of the baby, either with a pacifier or a chin strap, because it is meant to be open. Pressure is never going out through, only the excess pressure goes out through the mouth. So I would suggest do not occlude the mouth of the baby. Feed the baby if you think baby needs feeding. But what was wrong there? What camera is used here?
I found this on the web for pressure is never going out of.
So what's wrong? Which is wrong? The right is wrong. The right, they've used a cannulate. So cannulate should not be used for Ram's cannula. Ram's cannula, there should be some leak around the nostrils. If you snugly fit Ram's cannula, you can and land up with gastric perforation. So please remember this point. So what you should do here? This baby is on CPAP. What else you can do? Is this baby okay, or you need to do something else? So baby is on bubble CPAP. Saturation on 99, heart rate is all right, blood pressures are all right. This is on ventilator CPAP, flow of 5 FiO2. Flow of 5 FiO2 21%, and pressure is 5 centimeters. So what should we do? So Navdeep, please, no chin strap. No chin strap. Very good. So this baby continues to have some retraction, maybe a score of 4 or 5. So the best thing for this baby to increase the pressure from 5 to 6. He's maintaining normal saturation, but still this baby is asking for high pressure. So because there are retractions, you will increase the CPAP from 5 to 6. Okay. So look at the retractions, keep the neutral 8 positions, ensure the nesting, cocooning is done. let the baby be comfortable. If the baby is comfortable and is still having retractions, you need to increase the pressures. So this is what we should learn. Now, one more video here. Maybe you can tell me what is the problem here. What is shown here? What is the problem here? So this baby again is a CPAP. Temperature display is 37. Maybe this baby is on 21%. Baby is maintaining good saturation. So what is shown? Inspirate limb, no condensation. Baby is lying on the side. What problem is here? Baby is hypothermic, okay? Very good. So baby is hypothermic, yeah. So temperature should be well maintained, very good. What else? What is wrong with the CPAP? Now baby can lie on the side, the neutral position. Head and body should be turned, not just the head, but total baby is turned, so that's all right. You see here, you can see the water chamber here. So it is, what is happening? It's collapsed. So if it's collapsed, the water chamber, the water in the humidifier is not filled. You can see here, it is not up to the level. So why is the water getting not filled? It is auto chamber, no. Because they forgot to open the air vent. You can see here the air vent is not open. So if the air vent is not open, then you will not have okay. So you should open the air vent. So always have an audit tool like this, which will tell you whether you are able to give adequate CPAP. So in the top part, you can see what you have to learn as far as the unit is concerned. And for each one of this baby, you can fill up this line, the column, and see whether you are giving adequate CPAP or not. I will share these slides in the group. So maybe Rajesh will share with all of you. You can take this audit tool of the CPAP and then start working in your unit. Thank you. Okay.